very good afternoon. I think we are at the fag end of the day. So quickly, a couple of slides to go through to talk about the ESMO Immuno-Oncology, the annual conference data. This data preliminarily looked into Adagrasib with Pembrolizumab in the treatment of non-small cell lung cancer, those who were harboring the KRAS mutation. We did hear a talk in the morning about this KRAS. The drug is Adagrasib. It's a differentiated KRAS inhibitor. There is some rationale behind it to combine with immunotherapy. KRAS mutation is an oncogenic driver. 14% of the adenocarcinomas of the lung do present, and you can see in the picture. It's had selected properties, quite a good long half-life, dose-dependent PK, and it has CNS presentation. Its clinical activity is shown in patients with multiple KRAS mutation, not only in non-small cell lung cancer, and also treated, non-treated, untreated, and even with CNS mets. There are several data to support its combination of the adagrasib and immunotherapy. Can be used with anti-PD-L1, demonstrating an increased immune response and efficacy in preclinical models. Yes, it increases innate and adaptive immunity, and there's a figure showing that. Now we are going to get into our CRYSTAL study, CRYSTAL 1 and CRYSTAL 7. CRYSTAL 1 is basically a phase 1, CRYSTAL 7 is phase 2. We wanted to look into these unresectable advanced metastatic non-small cell lung cancer with KRAS mutation. They have not received therapies systemically, and stable brain mets were allowed. The first study looked into safety and overall response rate, duration of response, progression-free survival, and overall survival. The second study, which was a phase 2, did look into overall response, duration, progression-free survival. And it's a data which presented where adagrasib 400 milligram twice daily was used, and pembrolizumab dose remains the same, 200 milligram once in 3 weeks intravenous infusion to these newly diagnosed cancer patients harboring the KRAS mutation. CRYSTAL 1 had a median follow-up of 19.3 months, CRYSTAL 7 3.5 months. And that's the treatment-naive patient's tumor response, how it looked like. And if you see, the best treatment responses was observed in 57%. Responses were observed with PD-L1 different status greater than 50, 1 to 49, and less than 1. All 4 patients who responded did have a durable response greater than 9 months, showing an encouraging data. Grade 3 toxicities were seen, but no grade 4 toxicity. And that's how the protocol ran, with 75 patients enrolled, and finally the median follow-up of 3.5 and duration of treatment was 2 months. The age was balanced with good performance status. They did a sub-analysis on the PDL status, smoking history, sites of meds. In the CRYSTAL 7 study, yes, they looked into the grade of the toxicity. There was no grade 5 treatment-related toxicity. Median time to onset with the enzymes in the liver going up was 26 to 37 days. And treatment-related toxicity did lead to reduction of dose of the adagrasib and dose interruption ranging between 30 to 40% of the patient. Discontinuation of both drugs was only 3% in both the arms. So, yes, an acceptable toxicity. We do see these drugs in our treatment armamentarium now here. Objective response was ranging around 49%, complete response 2, partial 47, stable disease 40, and 11% of the patient did have progressive disease. The overall response rate, confirmed and unconfirmed, with CR and PR together were shown in the figure. Yes, in these treatment-naive KRAS mutated, the best response in the CRYSTAL 7 study. 49% across all PDL with a good disease control rate of 89%. Responses were observed reasonably as per the PDL status. And if you see the duration of the treatment, mean time to duration was 1.4 months. And some patients achieved responses in greater than 2 months. In the CRSF 7th study, for clinical activity, evaluated patients who were enrolled greater than 6 months, the data was cut and the overall response rate was almost 56%. And efficacy in patients who were enrolled greater than 6 months. So that brings us to the conclusion of CRSF 1 and 7 trials, where they evaluated the treatment of adagrasib concurrent with pembrolizumab, and it's one of the largest data set evaluating KRAS mutation and its inhibitor in combination with the PD-L1 and L1 checkpoint inhibitors in first-line patient with non-small cell lung cancer harboring the KRAS mutation. In this preliminary analysis, concurrent adagrasib and pembrolizumab had a manageable toxicity safety profile consistent with either agent, whether you use it as a mono or in combination, very low rate of treatment-related toxicities and which led to discontinuation. Yes, liver-related were predominantly low-grade, did occur early, and one patient had a little later, around 3 months. Adagrasib pembrolizumab demonstrated promising preliminary activity across all subgroups of PD-L1 subtypes. Based on these findings, the phase 3 trials plan to enroll the first line in non-small cell lung cancer de novo with the KRAS mutation. Again, evaluating the use of adagrasib BD 400 mg with pembrolizumab versus the standard of care with the PD-L1 status. So this study is going to start, and these are the acknowledgements. Thank you very much.